We talked a lot about imaging, and we maybe I'll move on to therapy. So castrate-sensitive prostate cancer has been a ton of data. And Dr. Satpute, I wonder if you could kind of walk us through how we think about all of the doublet trials and just, what are we thinking about when we're seeing a man with newly diagnosed metastatic castrate-sensitive prostate cancer?
Certainly. So it was about, I guess, 10 or so years ago, we had all these incredible trials, the Latitude trial, the Arches, the Titan. These are the trials that showed the benefit of each of these ARSI agents to be added to androgen deprivation therapy that improved the both progression-free survival and overall survival incredibly. And that really brought all these, initially as you know, they were in the CRPC setup, but eventually they got into the hormone-sensitive. When you look at these trials, there has been fairly comparable improvement. So we're talking about here abiraterone with the Latitude trial, the Arches with enzalutamide, and the Titan with Erleada or apalutamide, really seem to be quite comparable in that particular niche of metastatic hormone-sensitive prostate cancer. Now, the approvals might be a little bit different. Like, for example, the new drug, the darolutamide, the new kid on the block, it is not approved as a doublet, as you know. So things like that you need to keep in mind. But if you really think about the efficacy, they're pretty comparable. And then you have to, of course, look at the toxicities, which we might be talking about later.
Right. Yeah, and I think that's one of the things to get into is, how do you pick? You have 4 pills that have demonstrated benefit, and I realized that through the ARANOTE trial, we did not see an overall survival benefit with darolutamide, but it still had an excellent progression-free survival. So how do you put those into, Dr. Lowe, I was going to ask you, how do you put those into your equation, and which do you pick for which patient?
Well, I think just kind of piggybacking off what Dr. Satpute said about these different trials, these agents all show pretty consistent benefit and improvement overall survival. And unfortunately, right now, there's not a lot of data comparing agent to agent to see which one is better, which one has higher efficacy when you compare them to each other. So I think there's a lot of things that the clinician needs to take into account when trying to pick the appropriate drug, like what's the patient age, what are the comorbidities and medical conditions that the patient have with that, what are their current medications, will it interact with any of it? And I think, in terms of toxicities, I think it's, in most cases, older patients don't handle certain toxicities as well as younger patients. You may need to take that into account. Dosing schedule may be another one. How are these medications taken? Cost, coverage, those things that we try not to think about as much, but are definitely important. So I think, there's a lot of factors going into the selection of these agents.
And how do we think about comparative toxicities? Dr. Gonzalez, if you can talk about, you've been using these drugs for many years. How do you look at the 4 drugs and sort of put them into categories of toxicity?
Sure. So I think there was a comparative kind of review of the DEER trial, if I remember correctly, that kind of put these drugs into comparison. There was never a head-to-head evaluation in a clinical trial, but they kind of looked at some of these, and darolutamide seemed to be the one that was best tolerated from multiple different categories, including fatigue, nausea, GI. I know that some apalutamide has a rash component that can be pretty common in a certain amount of patients, so that can be a problematic problem for that. Abiraterone, I've been concerned with folks that have hypertension and other cardiovascular risk factors.
Yeah.
I believe enzalutamide has an issue with CNS and seizure risk, and so some of those things are kind of preeminent in my mind. Again, sometimes payers regulate a little bit your choice, but for me, I think the most important thing when I was first getting started, it was a lot of sequencing of drugs.
Yep.
You kind of start with ADT, an LHRH antagonist, and when that fails, you had something else, and when that fails, you had something else, and when that fails. I think we've seen through all of these trials and some of the triplet trials as well that kind of getting these drugs in early makes a huge difference. There are some minor differences as to which one you pick, but as long as you do complete androgen blockade, that is probably most important. I found it interesting in some of the trials too, with the addition of darolutamide, some of the fatigue went down. And I thought that was very interesting that there was actually less side effects than the placebo plus LHRH. So certainly if somebody has CNS disorders and seizure history, you would not use enzalutamide. If the rash is a concern, you can switch to another one. But I found from a fatigue, nausea, and GI upset, darolutamide to be my first choice.
Gotcha. I think a lot of folks are echoing that as I've talked to people about it.